Bismillahirrahmanirrahim. Today we will study RCOG Guideline about Polycystic Ovarian Disease, in which I will cover certain important points like Rotterdam Consensus Criteria, counseling of the patient regarding its long-term complications like cardiac disease, diabetes mellitus, endometrial carcinoma, etc. Moreover, from this guideline, I will discuss the treatment options of polycystic ovarian disease, starting from the lifestyle modification and pharmacological management to surgical managements like electrocautery and bariatric surgery. So first of all, I would like you to subscribe this channel, click like and share, and press the bell icon. And I would recommend you to watch this video till the end, as I have given explanation of the several ambiguous points in this RCOG guideline about polycystic ovarian disease at different points in this video. So first of all, we will discuss how polycystic ovarian disease is diagnosed. According to this RCOG guideline, it is diagnosed according to specific criteria known as the Rotterdam Consensus Criteria. And this criteria have suggested a broader definition for polycystic ovarian syndrome, with 2 out of 3 of the Rotterdam criteria being diagnostic of the conditions. Means there must be 2 points positive in a patient in order to label the patient as suffering from polycystic ovarian syndrome. Okay, so what are those 3 points? First of all, there should be polycystic ovaries, means there should be 12 or more follicles or cysts in the ovaries. Or there should be an increased ovarian volume of more than 10 cm³ on ultrasound. Secondly, there must be oligo or anovulation. And thirdly, there must be clinical or biochemical signs of hyperandrogenism. Now, how should women with polycystic ovarian syndrome be counseled regarding the long-term implication of their condition, and by whom? Well, there should be a proper counseling session with a woman suffering from polycystic ovarian disease. And such women should be informed of the possible long-term risk to the health that are associated with their condition by the healthcare professionals. Okay, so a detailed sympathetic discussion with the patient about her condition is very important. What is the risk of developing gestational diabetes in women with polycystic ovarian syndrome? Clinician may consider offering screening for gestational diabetes to the women who have been diagnosed as having polycystic ovarian syndrome before pregnancy. So what screening test we have to do? That is the OGTT. OGTT is performed at 24 to 28 weeks of gestation. And if it is positive, then we need to refer the patient to specialist gynecologist in diabetic service if we suspect any abnormality in that OGTT. And if you want to study more detail about OGTT, its indication, its interpretation, study NICE guideline about diabetes in pregnancy. And in the link, which is in the I button on the top right corner of this video, you can find that NICE guideline about diabetes in pregnancy. Now, regarding diabetes, there is another question in RCOG guideline, and that is, how should the woman with polycystic ovarian syndrome be screened for type 2 diabetes? That is also a very important point. First important risk factor is that of obesity. Women presenting with polycystic ovarian syndrome who are overweight means they're having BMI of more than 25 kg per meter square. And those who are not obese but have additional risk factors, they all should be offered the 2 hours 75 gram OGTT test. And what are those risk factors? Those are advanced maternal age, like age is more than 40 years, personal history of gestational diabetes, or family history of type 2 diabetes. So these are all risk factors which we have to consider. Moreover, we have to interpret the value of fasting glucose as well. In a woman with impaired fasting glucose, mean fasting plasma glucose level from 6.1 to 6.9, or impaired glucose tolerance test, means the plasma glucose of 7.8 millimole per liter or more, but less than 11.1 millimole per liter after 2 hours OGTT. In all these patients, we have to offer an oral glucose tolerance test, and that should be performed annually. Now, what is the risk of developing sleep apnea in women with polycystic ovarian syndrome? Well, a woman diagnosed with polycystic ovarian syndrome should be asked about different points in relation to the sleep apnea, like snoring, daytime fatigue, solemnness. And if these symptoms are present, we should offer investigation and treatment regarding sleep apnea when necessary. Next, what is the risk of developing cardiovascular disease in women with polycystic ovarian syndrome? Clinician needs to be aware that conventional cardiovascular risk factors calculators have not been validated in women with a polycystic ovarian syndrome. By that, we mean that all women with polycystic syndrome should be assessed for cardiovascular disease risk by assessing individual risk factors. And what are those individual risk factors? Those are obesity, lack of physical activity, cigarette smoking, family history of type 2 diabetes, dyslipidemia, hypertension, impaired glucose tolerance, type 2 diabetes. So these all should be present at the time of initial diagnosis. Moreover, in a clinical practice, hypertension should be treated. However, lipid-lowering treatment is not recommended routinely and should be prescribed by the specialists only. Now, what is the risk of having reduced health-related quality of life in women with polycystic ovarian syndrome? Psychological issues should be considered in all women with polycystic ovarian syndrome. And those psychological issues might be in the form of depression or anxiety. Okay, so we should screen the woman for depression or anxiety. And if the woman is found to be screen positive, what do we have to do? We have to do further assessment, appropriate counseling, appropriate interventional, and we have to refer the woman to qualified professional. Along with the cardiovascular problem, along with the diabetes, the risk of cancer should not be underestimated. So what are the risks of cancers in women with polycystic ovarian syndrome, and how should these women be screened? As we know that the women with polycystic ovarian syndrome suffer from oligomenorrhea, or they may suffer from amenorrhea. Okay, and that condition may lead to endometrial hyperplasia. And if endometrial hyperplasia is left untreated, that can lead to carcinoma of endometrium. So the good practice is to recommend treatment with gestodin to induce withdrawal bleed at every 3 to 4 months in such patients. And if there is no withdrawal bleed, then we have to consider doing transvaginal ultrasound. And on transvaginal ultrasound, if we find that the endometrial thickness is less than 7 mm, so it is unlikely to be hyperplasia. But if we find thickened endometrium or suspicion of endometrial polyp, then we have to do the endometrial biopsy with or without hysteroscopy. Now, regarding the breast and ovarian cancer, research shows that there has been no association. So we don't need to do any surveillance or any screening for breast or ovarian cancer in such patients. How should these women be advised on the lifestyle issues? It is recommended that lifestyle changes including the diet, exercise, weight loss are considered to be as the initial first line management for PCOS. So counsel your patient regarding these strategies for a reduction of the risk of the polycystic ovarian disease. Next is about the drug therapy. Is the drug therapy appropriate for the long-term management of the woman with polycystic ovarian syndrome? Well, we have certain insulin sensitizing agents like metformin and rosiglitazone and pioglitazone, but these have not been licensed in UK for use in these patients without diabetes. Metformin can be considered in women with PCOS who are already undergoing the lifestyle treatment, and do not have any improvement in the impaired glucose tolerance test. But there is no evidence regarding its long-term benefits. However, the NICE guideline about subfertility states that if clomiphene is given with metformin, it increases the chance of fertility. Weight-reducing drugs like orlistat may be helpful in reducing hyperandrogenemia. Now, coming to the electrocautery in PCOD, ovarian electrocautery should be considered for selected and ovulatory patients, especially those with a normal BMI, as an alternative to ovulation reduction. And it has been shown that this laparoscopic ovarian drilling decreases LH level, LH-FSH ratio, prolactin, testosterone levels in patients with a polycystic ovarian syndrome. Now, what is the prognosis following bariatric surgery? Bariatric surgery may be an option for morbidly obese women with a BMI of 40 kg per meter square or more, or a BMI of 35 kg per meter square or more with the high-risk obesity-related conditions if standard weight loss strategies have failed. And what is the best marker of polycystic ovarian disease? Serum AMH is considered to be as the best biochemical marker for polycystic ovarian disease. And what is the cause of infertility in polycystic ovarian disease? Raised serum LH level has been found to be an important factor in the infertility. I would like to complete my presentation with this quote, and that is, failure is not opposite of success, it is a part of it. Okay, thank you so much. Wish you all the best.